Aloha, everyone. Good afternoon. This CME activity is jointly provided by the Queens Medical Center and the University of Hawaii John A. Burns School of Medicine, Department of Geriatric Medicine. Joining me this afternoon is our interdisciplinary geriatric ECHO team. We are all willing to teach and share our collective experience and wisdom with you. Please welcome our advanced practice nurse, Courtney Nonokawa, psychologist Lucas Morgan, and our social worker, who is also our guest speaker, Sarah Tompkison. As a reminder, evaluations are required for CMEs. You can find evaluations by following the link in the chat or at any time on our website and email advertisements. We are currently offering continuing education for MDs, DOs, RNs, APRNs, and physician assistants. We are also offering NASW CEs for social workers and certificates of attendance for CNAs and students. NASW credits will be sent out monthly. For the rest, CME records will be sent out by Queens, usually mid-January. Your comments are very important and useful to the planning committee for future programs. A little bit about ECHO. We want to emphasize that this is an ECHO webinar which serves as a forum for mutual teaching and learning from experts and from each one of us on the front lines. As the ECHO motto goes, all teach, all learn. So it will take a community to create a wonderful community of learning. Our ECHO webinar consists of the following format: a short lecture from our expert presenter, open comments from the team, attendees' comments, questions, and examples for case discussions. Additionally, we invite you to present any geriatric case. Lastly, we request that you keep the case discussions HIPAA compliant. This includes not sharing the patient's name, birth date, address, and so on. Remember, we learn best from our patients and our clients. They are our best teachers. Now, have you heard about the gift that keeps on giving? That's Sarah. It gives me great pleasure to introduce our distinguished speaker. Sarah Tompkison has been a geriatric social worker since 1979. Upon retirement from VA, she pursued her interest in dementia care by working in memory care homes at an adult daycare day health program. She's currently the GWEP social worker instructor with the John A. Burns School of Medicine, Department of Geriatric Medicine. In addition, Sarah is a certified TIPA SNOR instructor, which is the positive approaches to care for dementia, and educator with them and dealing with dementia training. She is also a former VA REACH interventionist and a group facilitator. A little bit about her family life. She is currently a secondary caregiver for her father, who was diagnosed with mild cognitive impairment, and mother who lives with Parkinson's disease. She is passionate about reducing caregiver stress and burden in the state of Hawaii. So welcome, Sarah, and please take it away.
Thank you for those kind and lovely words, Rita Bell. You know, this topic is not just one that's professional, but as Rita Bell pointed out, I'm pretty passionate about it personally. And I'm sure everybody here in the audience, if you've not been a caregiver or what I like to call a care partner, at some point in time, you may be a care partner or have been a recipient of care. In this presentation, I'm going to be speaking specifically about unpaid caregivers. Those are those family caregivers, even informal caregivers. It could be the postman or the chaplain. There's a lot of, but the basis for the presentation is thinking about unpaid caregivers. Okay. Next slide. So here are the learning objectives. I really want this presentation to be interactive, engage you, and to really be meaningful, not again, only in your professional practice, of course, but maybe you can also take away what you've learned to help other people in your family or other areas that you come across seeing caregivers. So I'd like you to be able to describe 3 risk factors that can contribute to caregiver burden, be able to explain the purpose of the Zaret burden scale, and describe what would be some best practices or strategies for managing caregiver burden. And lastly, be able to identify at least one best practice or approach to improve caregiver health, emotional well-being, and to promote self-care. So I'll be speaking to both evidence-based practices as well as informed practices, best practices. Next slide, John. So I wanted to ask you as an audience, you can answer in chat. When you think about all these people on this slide, the photograph, what do you think are 2 things these people all have in common? Don't be shy. I'm looking in the chat. Okay. Yes, that's right, Judy. They all have dementia. And the second thing, hint, hint, there's someone in the photo with the person that's living with dementia. So what I wanted to emphasize is each of these people on the farthest from your screen, for the farthest of everybody knows Bruce Willis and his wife, who's his care partner. He's living with frontotemporal lobe dementia. In the middle top, there's actor Robin Williams, who passed away from Lewy body's dementia. He had a lot of support. His son is on the far left. I don't know if that's his wife or daughter, and then his wife. Again, in the picture photograph with Tony Bennett, who's a singer, recently passed away this summer. I believe he also had Alzheimer's. And then at the bottom forefront, most recently, former First Lady Rosalynn Carter courageously stepped forward with the support of her husband and other family members to let the community know that she was recently diagnosed with Alzheimer's. Okay. So although we're looking at different kinds of dementia, I think that this little video speaks to the crisis that we all are faced with, not just with Alzheimer's, but the facts about caring for people living with dementia. This is nationally. Thank you, John. So I have now a little quiz for everybody to kind of see how much we know about our family caregivers here in Hawaii. So we're going to show you the little quiz. Okay, here's the first question. So in 2022, what do you think were the number of unpaid caregivers in the state of Hawaii? Make one choice. We have about 19 people here in attendance. A few more seconds. Oh, we have 20, okay. Let's end the poll and see what answers we have. All right. So it looks like 43% believe that the number of unpaid caregivers are 60,000 and 75,000. The correct answer is actually 60,000. But if you ask me, I think this is an underrepresentation of the number of unpaid caregivers. And I'll tell you later on in the presentation why I believe that to be so. Okay, the next question that we have for you is how many hours of unpaid care is provided by caregivers? Again, how many hours of unpaid care do you think is provided by caregivers? Good job. We've got 22 people online, 16 responses. You can take a guess. Okay, we'll close the poll and let's see what the answer is. So the people that, what is this? It seems like they're neck and neck. There's half the group feels, I guess 47% feels that 70 million people are providing 70 million hours of unpaid care is being provided. The correct answer actually is 91 million hours of unpaid care is provided by our family caregivers here in Hawaii. Okay, let's go on to question 3. So knowing that there's 91 million hours of unpaid caregiving, what do you think the value of unpaid care in Hawaii is? This is how much money the state is saving because you have these unpaid caregivers. A few more seconds. Okay, we're going to end the poll. And let's look at the results. Well, congratulations. The 65% got it right. It is actually 1.9 billion, close to $2 billion that we're saving the state of Hawaii. All right, our fourth question is in 2021, the percentage of caregivers with chronic health conditions in Hawaii. What do you think was the percentage of unpaid caregivers that had chronic health conditions? Okay, we're going to end the poll. Pretty good. The correct answer is that there's 49.6% of caregivers in Hawaii with chronic health conditions. If you want to locate this data, you can go to the Alzheimer's Association website, Hawaii's website, and you can find they have a nice, they have other facts too about not just family caregivers, but the general population here in Hawaii. And the last question is, what do you feel is the percentage of unpaid caregivers with depression in 2021? Give it a few more seconds. Okay, we'll go ahead and we'll end the poll. And interestingly enough, the percentage of caregivers that were found to have depression back in 2021 was 16%. I'm sure now it's probably up to 20% because again, this data that they had on file for the Alzheimer's Association was 2 years ago, 2021. So yeah, and I'm hoping Dr. Lucas can chime in and Courtney, because in their clinical practice, they're probably seeing a lot of people that are feeling depressed as caregivers for people living with dementia and other illnesses. Thank you, John. So we're going to talk, this is an interesting topic for me, clinician caregiver engagement questions. So I think it's important for us as providers, clinicians, to start assessing with family caregivers or unpaid caregivers how they're doing. And so one of the first questions is, and I think it's to how we phrase everything. So you can paraphrase this any way you want, but I really think it's important just to find out when the care provider or caregiver is bringing in that family member to see you, to check in with them. And you might want to say, I routinely in my practice, I find that it's really helpful to pay attention to my patients' caregivers. Can you tell me a little bit about how you're feeling or doing? Because that will be critical to knowing too what's going on, not just with the caregiver, but you'll be able to also gauge what's going on it'll help you get more information about the patient that you're going to be seeing as well. The other aspect is we know caregivers often, maybe neglect's not the right word, but another term might be, we know that caregivers often overlook taking care of themselves or their own health. Do you have a primary care doctor, or when was the last time you saw your doctor? It's a fact. Most caregivers put their personal and their health care needs and they put it on the back burner. That's why they have problems with insomnia, depression, anxiety, and so on. Another question we might want to ask is, I know that many family caregivers can find their role to be stressful. How are you handling or coping with these responsibilities? How often do you get out of the house, or what do you do for fun? Many caregivers don't want to burden others, especially their children. So another question might be, are there times when you really need help, but don't ask for fear of being a burden? And that should be like a little red flag that or a signal that kind of makes you aware as a clinician, okay, this person looks really tired, looks very sad, etc. And they're having it's possible that they are having caregiver burden, but they don't feel comfortable asking for help. And that's what we see a lot. I'm probably preaching to the choir here. Who helps you with support or giving you a break with caregiving? Yes, Renata, thank you for pointing out that caregivers always prioritize the health of those that they care for. In fact, as you know, Renata, most caregivers die before the patient does because they just haven't taken care of themselves. Okay. I'm trying. Oh, there we go. It gets stuck. If anything this is the most important thing, the last two questions. So caregiving is a very hard job. We need to really validate and empathize with people. We need to really connect with our caregivers to let them know that it's a very difficult job. It is a 36-hour day. And to mention, we work with a social worker who has expertise in assisting family caregivers. And may I help you with a referral? Because it's so hard for people to ask for help. And lastly, what is concern for many of us is if anything should happen to that caregiver, you want to know, have they made any arrangements for someone to take care of the patient? And someone else had a comment. Oh, okay. Okay. Yeah, just put your comments and your questions in there. I'm going to ask Rita Bell or the other hub members to help field those questions. You know, John, my thing keeps getting stuck. Let's see. Okay, so understanding what caregiver burden is. I kind of liked doing this little research project too, because I found out that there's two main types of caregiver burden. I just thought burden was burden, but there's something called objective burden and subjective burden. And what is meant by objective burden is that for the caregiver, there's physical, psychological, social, and financial impact on the caregiver that is caused by disruptions to his or her life. So what they mean by disruptions to his or her life is that can include the amount of time the caregiver takes from his or her own personal life to care for the care recipient. That time that they take away can be in terms of the money that has to be spent for paying for caregiving. It could be the lack of time or lack of money that produces this subjective burden. So I know for myself there have been times, and maybe this is even now, I really I had to pull back. I was working full time, and knowing that my parents' care needs were taking more of a priority, I know at this point in time I have to pull back and work part time. But for a lot of other people living in Hawaii, it's it's not a choice that you want to work part-time. Some people are having to work two full-time jobs. But when you're caregiving, if you don't have an employer that really can extend beyond the Family Medical Leave Act, if that even exists for your company, it's really difficult again, because caregivers they lose out on time that I guess they lose out on opportunities for promotions and career advancement. And when they have to pull back on how many hours they work, or have to retire early or not work at all, they lose that income source too. So that's what's meant by a disruption to her or her life. When compared to subjective burden, again, for the caregiver, it's looking at what makes the caregiver feel. It's their self-assessment or evaluation of how they look at their role as a caregiver. And again, we have some caregivers that see this role of doing objective tasks of caregiving to be very rewarding. I had a caregiver that found much joy in doing laundry, cooking for her mother, sleeping. At first she was sleeping beside her mother, but then with the COVID thing, she started sleeping in bed with her mother, just really guarded and wouldn't let her. I guess she just kind of was the shadow, but she found it very rewarding. And then I've talked to some caregivers that have said, Sarah, I'm just not cut out for this. And it's not the personal care, and it's not even managing the finances, but I don't have the patience. I don't feel like I try to wrap my head around what's going on, but I don't understand why my mother's doing these things. And so oftentimes when we start to talk about giving caregivers tools, that's the best practices that we're going to address. Culture is another factor that influences subjective burden. There are some cultures where especially in Polynesian culture, from my experience, you won't see a lot of, I didn't find any Samoan families that would want to talk about placing a person in a care home, needless to say, even a nursing facility, because um, the expectation is the family or extended family would help take care. Asian families too are a lot different. We don't like to let other people know what's going on in our private lives, which is sometimes it's harder for us to ask for help and do this kind of advanced planning. So it's just, to me, it's important to keep in mind that if we can be respectful to other cultures, then you can take baby steps forward once you understand where that person is coming from. Subjective stressors such as negative feelings toward their caregiver role, or feelings of guilt, anger, not meeting the needs of the care recipient, it can produce subjective burden on the caregiver. So what are the caregiver burden risk factors? for most of you here today, this is probably not new information as far as caregiver characteristics. Most of our caregivers are female, although there's more and more male caregivers. I'm really proud my husband took care of both of his parents, and I learned about caregiving because I had the opportunity to be involved with him and my in-laws. Some of them have a limited education. The caregivers live with the person they're caring for, and there's high numbers of hours of caregiving, as we saw in that quiz, the poll we did. Most significant though is a lot of caregivers become socially isolated. I mentioned the financial stress. There's very limited choices that they have. But what I forget to mention is, even for me as a caregiver, I find sometimes if I'm not really careful, besides the isolation or sometimes feeling lonely, you sort of can lose your own personal identity. And so there was a time I just started severing my hobbies and outside interests. I didn't go out with my friends and just kind of had to step back and take a deep breath and start reassessing. Um, some caregivers do have some good coping strategies and self-efficacy, but again, culture is another important element for each caregiver that we talk to and work with. We really have to get to know who our caregivers are. As far as patient characteristics go, which can contribute to burden, is the stress, the physical stress. More than often, if the person receiving care has an increase in the number of assistance that they need with their day-to-day personal care, the instrumental activities of daily living, which include driving the person to appointments, managing their finances, it's sort of, and grocery shopping and cooking. That's not my thing, grocery shopping and cooking. I'm a better hands-on caregiver, but I had to tell my mom, I'm not a good housekeeper, as you know, and I don't like cooking. But surprisingly, what they found was it wasn't a burden. Most people didn't feel that the cognitive abilities were an issue for burden. Then again, for the patient, if their behavioral challenges, personality differences, and also looking at how to manage multiple medications. I mean, we're talking like 7+ medications. That can also be a factor with caregiver burden. And lastly, who doesn't have family conflict? I know, even my own family, right? Hold on to those thoughts and statements in the chat, and we're going to all get to that. Okay, next slide. Sorry, everyone. It's just this. There we go. I want to mention some other risk factors are truly depression and anxiety are real serious problems for for people that are caregivers. And as I mentioned, in the state of Hawaii, the percentage of caregivers with depression was 16% in 2021. I would be curious to see what that is in 23. But when we look at this slide, I want you to look to item B. Look at suicidal ideation. Isn't that crazy? 32% of our caregivers have experienced or talked about suicidality, or I have ideas of hurting or harming themselves, and even the prevalence of anxiety is really high. And this was at a national level. So it's important to also keep in mind that there are common chronic diseases for dementia versus non-dementia caregivers, and it's highlighted in this chart. As you can see in each column, the first column addresses those dementia caregivers that are more prone to have strokes compared to non-dementia caregivers. And in the last column, there's those that are non-caregivers. So I'm going to run through this a little faster because we're at the 12:30 mark, and I really want to hear what people are thinking, their thoughts or comments in any cases. So you might have heard of this screening tool for caregiver burden. It's called the Geri Caregiver Burden Scale. It was adopted excuse me. So originally it was like a 29 item. And here, most people, we use the 4 item screening version, which I'm going to show you. It's really simple. It's been proven to be valid and reliable. And the best part is it can be done by the caregiver. Or if you're in the office, you can even ask the MA or someone to ask the caregiver the questions. If the person scores 8 or higher, it's indicative of caregiver burden. It's a screen, it's not a diagnosis for anything, but because they're screening high, it should alert the provider or clinician to discuss with the caregiver some interventions. So this is just a sample of what you can see on the caregiver burden scale. So let's get to best practice and approaches for caregiver support. I'm going to speak to 4 of the best practices. There's the VA has their wonderful, robust caregiver support program. Catholic Charities has the Reach Community Program, which is an evidence-based practice, as well as the Savvy Caregivers Program. TIPA SNOW's Positive Approach to Care is an informed-based practice. I really think, you know, if given more time to do research, they'll prove that's evidence-based practice with family caregivers. Most of what the research that you can see on TIPA SNOW is research done with paid caregivers. And lastly, I have to give a shout out because despite all these 4 best practices, some people aren't ready to go into counseling. Some people don't want to necessarily go into a formal program. So I'm so grateful that there are caregiver support groups like those that are administered through the Alzheimer's Association, Project Donna, the Caregiver Foundation, and so on. And I'm going to leave you a slide with all of their contact information. So briefly, the VA Caregiver Support Program is for veterans, and it's one of 2 programs. The first program, which is the program of General Caregiver Support Services, is for veterans of all war eras that have to be enrolled in the VA, and they have a family caregiver, but the services that they can offer to those caregivers include skills training, coaching, they have telephone support, they have a monthly, they have a caregiver support line that's also available to them. And it tells you what the criteria are to qualify for this program. But way cool is that they can also provide individual counseling for these caregivers of veterans from World War, I guess it would be from the Korean conflict all the way up to the most recent war we had in Iraq and Afghanistan. They also provide respite care, which is a resource that offers medically and age-appropriate short-term services to these veterans, and peer support mentoring. So this just kind of tells you how you can enroll in the program. And again, it kind of repeats that there is a care, and in Hawaii, the VA Pacific Islands healthcare system does have a caregiver support program. But there's a lot of psychoeducational training and counseling services. And these are the highlights I want to make about some of the resources, not just for general family caregivers, but I'll talk to also those caregivers of the most recent war theater. The SAVE program just rolled out. It's a program that stands for Signs, Ask, Validate, Encourage, and Expedite. It's a veteran suicide prevention program. Building Better Caregivers is an online 6-week workshop program that helps caregivers in those 2 different ways. And this is another new one that just started, Annie Caregiver Tech Support, for a lot of our caregivers that have smartphones and are really comfortable texting and going online. This is really great. And lastly, it was the VA that started this Resources for Enhancing All Caregiver Health, which originally was called Resources for Enhancing Alzheimer's Caregiver Health. I'm going to run through this quickly. The second program that the VA has is for those veterans, and it's called the Program of Comprehensive Assistance for Family Caregivers. It's for those veterans that have been injured either medically or physically. They have a disability that has to be 70% or higher, and they were honorably discharged. And it is expected the veteran's going to need at least 6 months of continuous in-person personal care. But look at the benefits. The benefits are threefold. The veteran not only can designate a person to be their family caregiver, but they can have up to 2 secondary family caregivers. And these are the benefits available for the primary and secondary caregiver. They get the same training that the general family caregivers get, but they also get mental health counseling. They might be eligible for travel, lodging, and financial assistance when traveling with the veteran. They also can get a monthly stipend. They get payment. And the amount that primary family caregiver gets paid is based on the veteran's care needs, the level of care needs, and where they live. They also can get CHAMP VA, which is a health insurance benefit, if they don't have any health insurance. Lastly, this caregiver support line is where you can call if you want to get the name and the contact numbers for the local office here in Hawaii. REACH is the resources for enhancing Alzheimer's caregiver health in the community. It's been a product of 20 years of research. REACH community is based on the successful REACH VA program. It has been shown to decrease burden, depressive symptoms, the impact of depressive symptoms on daily life, and the potential for abuse is measured by caregiving frustrations, etc. REACH community is a caregiver support intervention. It's delivered by certified program coaches. And actually, this is where I want us to spend a little more time talking about how REACH community was rolled out, and Judy's here on the line. It was rolled out maybe just before the pandemic in 2020. It outlines for you how the program operates, and that they have certified community coaches at Catholic Charities. The REACH community does offer in-person or remote services, remote services, virtual. And the caregiver right now, caregivers can make self-referrals if they're interested in enrolling in the REACH community program, but they're not taking referrals from the agencies. The next program is the Savvy Caregiver program. This is just an outline of what the curriculum is and how it rolls out, and information about the content of Savvy. Again, it focuses on helping to educate caregivers, making them more knowledgeable of dementia diseases, the elements of cognition, caregiver self-care, decision-making, and expanding family support. And it's through weekly sessions, interactive activities. They have some group homework, but really good. And in multiple research evaluations since 2002, nearly all the respondents who participated in Savvy Caregiver reported increased skills, knowledge, and confidence, and they would recommend the program to others. They've also reported reduced caregiver burden, depression, and distress. Did you know Hawaii had its own Savvy Caregiver program? This was through an ACEL grant in Hawaii. There were 9 people that have been trained, and we have 6 certified Savvy Caregiver trainers. In fact, our very own Dr. Lucas Morgan and Dr. Poki'i Balaz are 2 of the certified Savvy Caregiver trainers. And most recently this summer, up in Papakolea through the Kula program, they offered a modified version of Savvy Caregiver. Here's some feedback I'd spoken with Dr. Morgan about. They offered about 6 Savvy Caregiver classes. They had a total of 100 family caregivers, I believe. And Lucas, correct me if I'm wrong, I think they were done hybrid. You did some virtually, maybe during the pandemic, and then you went in person.
Pre-pandemic, they were in person, and then pandemic was virtual, and then we did some hybrids as the pandemic progressed. So
yeah,
playing
and
with the format.
Yeah, that was wonderful. And, per caregiver feedback, again, consistently, both in the pre and post tests and questionnaires, the caregiver said it improved their knowledge, their understanding and skills, their confidence regarding their role as a caregiver for a person living with dementia. So recently, there's more modified versions of Savvy Caregiver that are rolling out, and this is just a list of them. And I highlighted that the Savvy Caregivers for Native Hawaiians came out think it was in July and August. I haven't called Kula to see if they're going to run another round of the Savvy Caregiver. I don't know, Rita Bell, did you hear that NTG for intellectually disabled and development disabled is thinking about creating a modified version of Savvy Caregivers for that population?
Yes, we are looking at partnering with our state DDD division and doing a pilot here.
Yay! And then lastly, I want to speak about Teepa Snow's positive approach to care. Teepa's an occupational therapist, but she has extensive background and personal experiences related to dementia. And she led to the development of a care philosophy called the Positive Approach to Care, PAC. And the PAC aims to educate the community as a whole. That's the caregivers, what they refer to as care partners, to understand brain changes that result from dementia. And care partners also learn practical approaches that accommodate for those changes. So what I like about Teepa Snow is, as most of us know, the scales that we understand to stage dementia is one of three scales. We have the global deterioration Reisberg scales, there was the Allen cognitive scales, and with the Alzheimer's Association, they have another scale. It's either beginning, middle, or end. But it's really confusing for me, if not other caregivers. So Teepa created what she calls the GEM state classification model, and she uses 6 different GEMs. And they, the 6 different gems, if I got it right, and maybe Jen's here, there's the sapphire, the diamond, the emerald, the amber, the ruby, and the last stage is the pearl. But most importantly, her philosophy is, if you understand how people in these different gem states, they can go into different states as opposed to stages, it allows the care partners to provide the right care and the right support at the right time. And in the end, it helps the person living with dementia shine. So I really like that her focus is on, why do we need to focus on people's losses? We know what they've lost. Let's focus on what they have left. Let's target what abilities they have. Yeah. Hawaii does have some PAC certified independent trainers besides myself. Dorothy Colby's another trainer. We have 2 other people. Gina Hashiki is with Arcata Family of Companies, and Pat Bemis. But we hope to train more people. We're offering a champion day in the month of December. We have people from other facilities, I think Kahala Nui, Arcata, that are getting trained as PAC certified consultants, coaches, etc. And this is where you can refer to the research that has been done on positive approach to care. I wanted to mention before we close and ask for people's input, if you can get to this website, Benjamin Rose Institute, what I love about it is all those 4 practices, best practices I mentioned in the beginning, in addition to more best practices. If you go on this website, it's way cool because it will show you like over a dozen best practices that have been developed across the United States. And you can compare the different practices side to side, and you can see some programs have no fee. Some of the programs offer a fee when we're applicable. And you'll see from the person that developed this practice for caregiver support, they have research on it. They look at experiences of delivery sites and so on. So here's my thoughts about caregiver support. And I hope you'll all chime in and tell me whether you agree, maybe you disagree, but I want to know what you're thinking. First and foremost, it's important to remember no 2 caregivers are alike. In other words, one intervention doesn't fit all approach, and it doesn't guarantee a decrease in caregiver burden. We need to start thinking about the importance of doing initial caregiver needs assessment, because we need to start looking not just at their safety, but for the safety of the people they care for, as well as assess what the person that's receiving the care, what their physical health is like, if there's any depression, anxiety, etc. Interventions that we can look at more, we need to kind of explore more types of interventions that place an emphasis on the individual needs of caregivers that might have the most benefit and effect to ultimately reduce their objective and subjective burden. And based on research, interventions that include more than one component have more positive results. So for example, let's target the behaviors of the care recipient as well as provide education and support to the caregiver. When done hand in hand, I feel this is going to offer more positive results. Lastly, findings on the effectiveness of all types of caregiver interventions to reduce caregiver burden have been mixed. Some researchers speculate that this variation in the interventions and its effectiveness, it stems from the fact that the caregiver situations, their needs, their perceptions of stress and culture vary significantly themselves. So this is the next steps for caregiver support with dementia. I would like us to think about how can we start working more collaboratively with our government agencies, the nonprofits and private agencies to address direct care workforces to meet the dementia care needs in our state. We need to think maybe establishing a clearinghouse for just caregiver support services. And let's all collectively combine information and data to show who may need caregiver support services, but they just don't meet current eligibility requirements. So for the Kapuna Caregiver Program, if you haven't heard of that, those caregivers have to be employed in order for them to receive benefits through Kapuna Care that helps to subsidize adult daycare, day health, or respite care. But yeah, I think it's a really big thing that troubles me. Next, let's look at translating and adapting other evidence-based approaches that not developed specifically for caregiving, but can be used by family caregivers. Develop a family caregiver study program that uses an interdisciplinary track of courses from multiple academic disciplines, because it's not only the physician, it's really a team. It's like our hub. It's all disciplines from medicine to pharmacy to dental to psychology. Everybody has something to contribute. We need to determine where and how cultural expectations and caregiving competencies intersect and interact. And lastly, identify which care events trigger an assessment, update, or contingency plans for caregivers. Begin studies about special caregiving populations and groups that have not yet been the subject of research. And I'm really, I just took this training on how to screen for dementia with persons born with intellectual disabilities or developmental disabilities. But what about our aging elderly that are homeless? What about those elderly that are, I call the elder orphan, that don't have any children? They have no siblings. What do we do? Who's going to help care for them? And then we also have the LGBTQ, population, and it goes on and on and on. So this is the last slide. This is mom and dad. Dad just turned 94 and my mom's 93, just turned 90. So thank you for your interest in the topic, and I'm hoping it will have some value in your practice as well.
Well, thanks so much, Sarah. I really appreciate that presentation, full of information, resources, things to think about. And yeah, I wanted to open it up to folks here today with us. We did have one question to start it off with, and you mentioned support like social workers, and Don asked, what if there are no social workers to assist the caregiver? And I guess before even that question, I'm curious how you would, define what kind of services getting outside support from a social worker could help a caregiver with.
Your question, that's your question, Lucas.
Yeah.
It is the hardest thing to even get caregivers to ask for help. So you're right about where to send people. And we have some great agencies besides Catholic Charities for Elder Services. I would say The senior helpline through the Elderly Affairs Division, they have staff that can screen. If you do have I know if you have a geriatrician, you're going to find a social worker. If you have a primary care physician, they may know of someone in the outpatient clinic, if they're affiliated through Kaiser or some of the other HMOs. But I don't know if that's answering the question, Lucas, but it's really just trying to assess where that caregiver is. I mean, just trying to find out what is it that their need is, right?
Right.
Where they're
Right.
coming, because it may be something as simple as I found, because I get people calling me and friends and family, and someone, all they needed to know is, do you know the number, Sarah, for handy van? So I say, or how I apply for handy van? Of course. But then it may be something more complex where I've had people call saying, I'm losing it, Sarah. I'm getting maybe 4 hours of sleep. My husband doesn't even know how to get to the toilet. And this happened last week. He's urinating. He's urinating all over the place, behind the television, in the sofa area. I'm ready to strangle him. So we just had to talk her down, and I had to meet her where she was at and spend a good 15 minutes just listening. And then from that point, asking her how I could support her and what did she want to try. But it's, to find a social worker, that's, I mean, if they're affiliated, if the client or if the patient has an affiliation with any of the HMOs, or they make a self-referral to some of the community agencies besides I don't even know if Child and Family Services has social worker. Judy, does Child and Family Services gerontology program have social workers available?
They used to, but I don't know if they do now, because they used to have a gerontology program per se component, in the system, but they do not have that.
Yeah, and I do know that with Project Donna, they at the risk of them choking my neck, I do know Project Donna, which is another agency providing support. They do have social workers, and they're trying to get a couple of more retired social workers to help provide that counseling and support to family caregivers.
I
Because
see Maria.
Judy, you and I know
Morel.
them.
Sarah, can I add
Yes.
to it? Give more information.
Yes.
So Project Anna, one of our services are counseling, one-on-one counseling with caregivers. Right now, there's 3 of us that are available. So myself, and 2 volunteer counselors, and we all have our MSWs. So we are flexible in meeting caregivers. Often we do the counseling over the phone. However, we have met people in person or video call too.
Thank you, Maria.
Thank you
And
for letting
Judy.
me share.
Yes.
Also a
And-
comment that if
Yeah.
there's no social worker, I think we just need to empower the caregiver in terms of letting the patient know what is really going on, and that they need to accompany the individual to the doctors, because then a lot of the doctors are going by what the client is saying, and that 15-minute time interval goes really quickly, and they say, "Hi, I don't need any help." That's what they're gonna go on, and it's not that they're bad. It's just that they really don't know. So what we usually tell families is, track of one, and that's, make appointment to see the doctor and go with the doctor. Go with your loved one to the doctor. Let them something that there can be a discussion. A lot of times, a lot of the seniors go by themselves, and then families don't know what is really being said or not, so they have to involved in that component.
Yeah, I just want to piggyback what Judy's saying. I love it when I never used to go with my parents to the appointment, and we knew something was up when they come back and we say, "Oh, how was the doctor's appointment?" "Fine, everything's fine." "So how was it fine?" "I don't know. It's just fine. Everything's the same." And then we found out Dad had recurring prostate cancer the hard way. He couldn't walk. So I went, dang. And, he had the MCI, so it wasn't his fault. He doesn't do it purposely. But I mean, he kept telling the doctor, as with regards to having a PSA test done, "Nah, don't need any test." And then it had progressed, the prostate cancer, to his hip, where like termites were eating away at his bone. And, he's been in 5 years of chemotherapy and he's recovered with radiation. But Judy's spot on about, I guess it really is important for both family caregivers, even paid caregivers should go in to the doctor's office, care home operators, foster homes, whatever. I mean, how else are you going to really give a clear picture of what is going on at home with your patient as well?
Is that families can also, ask, order a or recommend a gerontologist. Somebody area treating elderly, and also neurologists too, because then they also look at different things that may be missed, that maybe the PCP might not really know as well. We need to encourage families also that they need to get more involved and how they can and being the voice for them when they go to meet people.
To add to what Judy and Sarah mentioned, caregivers in our group some are really tech savvy in that they use emails and the MyChart app to talk to their care recipients' doctors. And part of it is, when they go into the office, their care recipient doesn't want them talking to their doctor, but they have a lot of concerns. So we talked about, emailing the doctor beforehand, or giving them a call and sending their questions beforehand, before the appointment. But a lot of them, when they can access MyChart, they really like that platform.
Okay, gang. Well, thanks, Maria. And thanks, everybody, for your comments, just being conscious of the time. And it sounds like from a lot of folks' comments verbally and on the chat is a lot of family members may be limited by even knowing what resources are available or how to access those resources through their health insurance or other kinds of support. And so I think it's important for all of us here, in whatever roles we have, to be compiling resources. And so asking of what do folks have access to now, and what are they lacking, and being hubs for folks to continue to get support that they need. So please remember there's a link for your evaluation for your CME credits, and really want to thank everyone for joining us today, and for Sarah for a wonderful talk and a really excellent comment. So really appreciate everyone being here today. Hope to see you next time. Oh, Sarah, you muted. Sarah, you're muted. Are you?
Can you hear me?
Yeah.
Okay. We need to think about a community clearinghouse for caregiver support. If the VA was able to establish a caregiver support line that's open I think maybe it's 6 days out of the week,
till 10 p.m. I mean, we could answer some of the people's questions in the chat, you know, but hopefully government will think about that, to have like a support line, and you have staff on the support line that can answer these calls. Oh, you're looking for a social worker, or you're looking for a support group. So that's, I guess, I'm just pretty sorry, Lucas, I'm pretty intense.
No, that's a great idea. And the more resources and hubs and centralization of things and accessibility, the better. And so every little bit helps. So thanks again, Sarah, and thanks everyone for your participation today. Takes a village.
Thank you. See you guys next month. Thanks, Jen.